So we have done some work in the cold rooms, so extending the specifications to larger devices. We have looked at the storage in the districts, and here, so we know that ILRs are sometimes putting a risk of freezing vaccines, and also another issue is about voltage regulators that are not robust enough. So CHAI is having a project with WHO looking at TPP and a grading system for appliances. And this I will not speak about it because there is a poster downstairs that you can look at, and which is really clear on explaining what we are speaking about here. The health facility vaccine storage. So, of course, the main work that has been done is on solar power devices. And we were lucky to have Steve McCartney leading that work with a lot of experience from himself in Colombia and other countries. We have developed two published specifications, one on the SDD and the other one on solar systems. And we have now a first draft for the freezer. As Diana mentioned yesterday, so we have a guideline on the introduction of solar systems, which I think it's an important document. And during this conference, you will hear about the Path and Self Solar Energy Harvesting Project, and I think this is part of one of the session. One important work that has been done is to relook at the decision tree on the selection of appliances. So of course we have introduced in that selection SDDs in precedence to battery appliances, and also the use of long-term passive refrigeration devices. We have eliminated the devices on kerosene, and we have introduced a new band according to how many hours in the day you have power.
Don't make me do it, Denny. Don't make me do it.
I'm finishing.
Finish
well,
up,
you
please.
took a long time introducing the topic, so. And we were late.
Finish up, please.
So the last, going down into the supply chain, so we need to consider further outreach, and we looked at what I call, I don't know if you call it that way, but I call it health post. And so we have pre-qualified for the first time the RTEC, which is long-term passive devices, and we see it as a solution, eventual solutions for that level. But we need much more experience about it, and there is a field study going on with PASS in India. Just to mention, to be very clear, this model is not recommended for transport. I can repeat it. This model is not recommended for transport. Last topic is monitoring devices, temperature monitoring devices. Well, we are a little bit lost here. Too many devices, too many things. So my recommendation is these things need to be or to remain very clear. So we have introduced an approach on segmentation, and each product is to be very clear branded, and that's a call to the manufacturers. When you brand your product, make sure the user will understand the purpose of the device. So that's very important. We have introduced locally centralized systems as well as remote monitoring temperature system. Those are two different systems, one being local, the other one being using clouds. That's how we do the difference. There has been quite a lot of work done, especially during the workshop organized by UNICEF in Zanzibar, and we have adopted a segmentation approach, and our requirements are grouped into hardware and software. Thank you.
Thank you, Denny. I'm sorry to rush you, but if we don't stick to time, we'll throw everybody else off for the rest of the day. So there's the manufacturer's marketplace. I'm sure some of those things that Denny showed are next door. Dereje, can I please invite you?
Oh, I owe you beer.
Thank you, Diana, and good morning, everybody. I will be presenting on behalf of Supply Division. My name is Dadja Essoya. I'm from Supply Division. In the interest of time, I will rush to my presentation.
Can you get closer to the mic, Dereje? We can't hear you.
Can you hear me now?
No, maybe put it closer to your mouth, up higher, yeah.
UNICEF, as we all know, has a key role in immunization procurement. That's including cold chain equipment. And in 2014, that's last year, we have been able to procure cold chain equipment worth of $40 million to 80 countries. And in order to provide this service, we need to structure in a certain way, and this is how we are structured. The cold chain unit is under a center called Health Technology Center, and that is, again, in the Deputy Director Supply and Program. We have a total of 9 staffs. 4 of us are working in the technical side, the other 4 in the commercial side, and we have 1 unit lead. Our support can be categorized into 2 broad categories. One is we provide access to supply and performance, and we also work with partners in capacity building. Having said that, this is a procurement trend. This slide shows the procurement trend since 2008, and I would like to focus, draw your attention to this color, the beige color. And as you can see, that represents the solar direct drive refrigerator. So we have started procurement of solar direct drive refrigerator in 2010. And in 2010, the proportion of that refrigerator is quite small. And as we go to the 2014, the proportion becomes bigger and bigger. And in fact, in 2014, the total amount of procurement that we have done for SDDs were around 33% of our total procurement. So we can see that there is a steady demand for SDDs. The other thing that I want you to draw your attention is on the red color. That represents the absorption system. So it's good to note also that despite the fact that the trend is declining, there is still demand for absorption systems. This is a throughput for 2014, and as you see, 38% in 2014 of our throughput is on solar systems. So if we compare that figure with the 2011, the throughput has doubled, and if we compare the same figure with the previous year, that is with 2013, the throughput has increased by more than 34%. This shows how the workload in the cold chain unit is. This is off-tech since 2011 up to 2014, and the red color shows the procurement, actual procurement versus the forecast. As you can clearly see, there is an issue with accuracy of the forecast, but there is a clear shift away. We can see a clear shift away from absorption and battery-based solar refrigerator towards SDDs. And this new technology, SDD is relatively young technology, and it requires closer performance monitoring. And I know there are some partners who have already engaged in that, and that's something that we need to encourage. And maybe we will also hear from our colleagues later on how the solar direct drive refrigerator, the experience on SDDs. The other update that I would like to give you is our cold chain support package. It is a guide for cold chain planning and procurement, and it has technical and commercial information related to planning and procurement of equipment. It has a general procurement information, product-specific information, and frequently asked questions linked to the web resources like PQS is there, TechNet is there, our supply catalog. It can be accessed through the cold chain support package. By the way, for those of you who are interested in knowing more on support package, today at 12:30 there will be a poster gallery. I will have 15-minute presentations there, so you can come and have more on this cold chain support package. Last year, we have issued an RFI on temperature monitoring devices. RFI is a request for information with the objective of, we know that temperature monitoring is of critical importance. In fact, the next presenter will be talking about that. So we have certain objectives to do this RFI, and we would like also to know how the other industry monitor the temperature, like the pharmaceutical industry, the food industry, and the IT companies, courier services. How do they monitor their temperature, their products? So in the interest of that, we issued an RFI last year, and a total of 38 companies responded to the RFI from different sectors. And after analyzing that, we saw there is some trend in the technology. That is, one of the trends that we saw was there is a shift from the passive to active data monitoring, transmitting devices. Some suppliers, some industry also use GPS to locate their devices. There is a trend in monitoring of multiple parameters, not only temperature, but also light, shock, and other parameters, because there are some other products which are sensitive to these parameters. There is also a trend towards wireless data communication technology and system and modular approach also, not just one size fits all. So the outcome of this RFI was
5 minutes.
Okay, the outcome of this RFI was we have identified some products, and the products meet the need. In fact, that means some of the products that have been identified by this RFI can comply with WHO PQS requirements. We have also identified some gaps in the market, especially remote temperature monitoring devices for RTM solutions for ICT for locations, and of course clear policies on data protection, and also address issue on recurrent costs, especially on RTM. The other update I would like to give you is on the survey that we did in 2014 on WICWIF, that is working cold room and working freezer room. And we did that because we wanted to know, just not procurement, but after we procure, what will happen to the equipment? Will it be installed, commissioned, and being used? So in the interest of that, we did a survey, and we identified that almost 70% of the WICWIFs were installed and commissioned, but there are certain proportions, even after 2 years, they were not installed and commissioned. What we got from this survey was the perception by countries, especially on the ordering process, was positive, but the biggest problem was on the installation. And there was a significant difference in performance of equipment depending on who contracted the installation service. So I will skip this one. You can see here that from the time the PO is placed, how many months does it take up to installation and commissioning? And you can note that in one of the occasions, it took 23 months, that is 2 years. So there are different modalities to conduct installation. It can be installed, the contract could be through UNICEF supply division, the contract could be through country offices, government, and sometimes there might not be any contract because the government technicians are capable of installing the cold room, so that will not be, contract might not be required. So in that case, this is how the performance is, the performance result you can see is there. So the other update is about UNICEF Supply Division has some SDDs in its premises. We are trying to assess how this new technology is working, and it's also for our service a kind of learning curve, how these products are doing, and also to showcase to our customers who are visiting Supply Division. So those of you who, for any reason, will be coming to Supply Division are also invited to come and see our showroom. And this is my last slide. Our plan for this year is, we have done, as you know, a request for information for temperature monitoring device. We want to push towards that direction. We want to communicate with the suppliers and then encourage them for pre-qualification. And at the same time, we would like also to have an RFI for solar technologies. We would like to see whether there are other technologies in the market. So we will be issuing another RFI, but this time for solar technologies. We are currently working on field performance evaluation protocol development, and as we speak now, the protocol has been tested in Kenya and in Senegal. Demand forecasting for cold chain equipment is underway, and it is at its final stage. And we have also planned to conduct a field performance evaluation for solar technologies. And in our cold chain support package, as I have said, the cold chain support package has different components, but it doesn't have a cold chain maintenance section in that, and we have a plan also to include the cold chain maintenance into our cold chain support package. And that's all I have. Thank you.
Thank you very much, Dadja. That was very informative, and thank you for being impeccable with time. Benjamin, on temperature monitoring evidence.
Good morning, everybody. So thank you. I've got 2 minutes left. No, okay. Before I start, there are 3 things I want to take away from this hopefully short presentation. I'll try to be in time. Temperature excursions are an issue and are still an issue. They haven't gone away in the last few years. Second point, we're making progress, but we're still far away from implementing even the basics. And we will show you some new ideas of how we want to rationalize about why to invest in temperature monitoring. So, why do we bother about temperature monitoring? The immunization supply chain has kind of 3 objectives. The first point is that we want the vaccines to be available, that they are potent, and that resources are used efficiently. But what happens if you've got a temperature excursion? Well, if it's undetected, you put potentially a damaged, you inject a potentially damaged vaccine into the child. So it's not a very efficient resource use of your vaccines, because you maybe don't get zero conversion. And what happens if you detect the temperature excursion and you actually act on it, and you maybe do the shake test and the vaccines are damaged, you throw them away, or you have to get rid of them because of cumulative heat excursion, you have wastage. So that's why we care about it. And temperature monitoring is really a way forward to help you detect if you have any excursions, and helps you take actions. The famous bubble chart, I just clicked through it because basically there's more and more freeze-sensitive vaccines in the market and being introduced to countries. And I want to tell you now really 2 stories of what happens in a country. This is data from some temperature mapping, where we put the temperature monitoring device next with a vaccine, and we trace it from the national level all the way to the distribution and to the health facility. So this is like over 19 days. So this was kind of a relatively happy vaccine. It was sort of between 2 and 8 degrees with a few sort of excursions. We don't know exactly, I can't tell you exactly what happens there, but it's short excursions. Now, there's another vaccine, same country, 1 different route, but this vaccine was really called at some stage and really hot other stages. So this vaccine traveled through the supply chain, and there is no, I don't know if it was used, we don't know this information, if this vaccine was actually injected or not, but it just shows you what happens to the vaccine at the country level. So too hot, we actually have the VVMs, so they're very helpful. They can help you how to look at cumulative heat exposure, and it's kind of easier to detect. Yeah? The EVM data shows that over 90% of storekeepers and health workers know how to read the VVMs, but that is just asking them if they know how to read the VVM. We also don't know if they then actually act on that. That's always the issue we face. Then we have temperature monitoring, twice a day, your storage, you map your temperature. But then also always the issue, what happens on weekends? What happens if nobody went and checked the store? We don't know often. And then the problem is we have the harder to detect freezing. And, there's a shake test, but how do you identify freezing and how do you know if products have been frozen? And EVM data shows as well that only 11% of facilities pack freeze indicators with deliveries of freeze-sensitive vaccines. So I'm coming here, and there's two people who were part in the room, who were part of this study, Sophie and Joni, sort of a systematic literature review in 2007 showing that a lot of vaccines were exposed to freezing. So with Pat, we recently had a workshop in New York, and Pat passed another survey of the literature, and I'm going to quote from here. So Thailand, there were some 6% and 6.4% of the time vaccines were frozen. China, also an issue. Malaysia, I'm going to click through them, you can read them. There's all references, just like the main message is like freezing is still happening. And then this is some data from two UNICEF temperature monitoring studies, both in Asia here, two countries. And I just want to highlight here sort of the amount of freezing that took place, especially during transit, something between 20 to over 40% of the time. Also a little bit of freezing during storage. So freezing is still, this is my first point, it's still a major issue. There's more evidence, I'm going to click through this a bit more. There's some studies that link now, we have studies linking the freezing to potencies and to infections. But we have also good news. We have several studies now coming out that show the implementation of systematic temperature monitoring can work and produces positive results. In Vietnam, this was shown as well as in Tunisia. So I'm not going to go into all the little case studies here. They're all referenced for you in the bibliography to save some time. So what is WHO recommending? So I try to simplify it and hopefully not too much, Denny. Walk-in cold rooms, you should have central temperature monitoring systems, refrigerators, 30-day temperature loggers, and freezers, stem thermometer, and a few other devices. What I really worried about and care about is like, what do we know from the EVM? From the EVM, we know only 40% of all central and regional walk-in cold rooms have a central temperature monitoring system implemented. So for me, the question is how can we move this up from 40 to 100? Because we store the most value of vaccines in there. And recent news from some countries, if you followed the press, haven't been really good about what happens sometimes in national stores. Same with the refrigerators in the lower levels. We only have 40% of fridges are equipped with continuous top monitoring devices. So there's still a way to go. But also there's a question, maybe are there other new technologies? Are we sticking just with that, or are there also new technologies? And Denis said we had a workshop on remote temperature monitoring in Zanzibar recently. So the question is, are there new technologies that help us to make the system more reactive? So out of the workshop in Zanzibar, which Chai, PATH, and WHO, UNICEF, and many other Village Reach participated, the question came out, how can we actually measure the benefit and the cost of investment into a system? And later on this afternoon, you will, Tara and Mercy will show the tool, and the tool will soon be made available. We made a very simple cost-benefit analysis. We looked at the upfront cost of investment into the system and the ongoing recurring costs of different systems, and looked at the benefits. And if we look at the benefits, how did we do this? We kind of looked at the risk of freezing. We said VVMs kind of should take care of the heat excursion, but what is the risk of freezing? Now, we did some very simple modeling, is too much to say for this kind of putting a few numbers together, but what is kind of the average value in a national store of a EPI target population of 1 million children? There's vaccine, 4 months of vaccines are stored, $7 million. In the regional store, that serves 125,000 children, it's about, $653,000. And at the health center, serving 300 children, 520. So it depends, we can play around. This is just some assumptions. But what is important, that 72% of the vaccines in this example, and we looked at sort of a Gavi-eligible country, 72% of the vaccines are at risk of freezing. So there's a big chunk of money tied up in these stores and also at the lower levels that could potentially freeze. And if we can reduce the risk of freezing or reduce the number of freezing events, then there is a benefit of investing into the temperature monitoring. So next steps, mentioned already, a few things have been developed. A new vaccine management handbook will be issued soon. UNICEF will issue a practical guide for 30 DTR implementation and also looking at remote temperature monitoring devices. The cost-benefit analysis tool will be published. And then Denise said as well, there's new protocols for remote temperature monitoring devices. So what can you get from TechNet? First of all, get inspired. There's a lot of manufacturers here showing their devices, so look at them, play around with them, and give the manufacturers feedback, because they don't often can interact with the users or you guys. So give them feedback. Tell them, is it really the best user-friendly device that they have, or can they maybe improve that? And I personally think we can improve the whole some of these designs. You can learn from some successes and failures, in the moment some presentations, but also some posters downstairs, so please look at them. And then don't think devices. Temperature monitoring is not about devices. It's about system. It's about choosing the right device, having the right process in place, having the right system. Only then you have success. So don't forget the user. It's not about dropping in devices. It's about user, supervision, taking action on data, and also think about how this links into the overall health system. That's it. Thanks.
Thank you so much, Benjamin, both for helping us gain time, but also just having such an illuminating and thought-provoking presentation. While you were presenting, I was thinking about the fact that I think it was back in 2004 at the TechNet consultation in Antalya, Turkey, where Kerem Nelson, for the first time, presented Indonesia's experience with the temperature monitoring study. It was one of the first that had been launched globally. So it's frustrating to see that the problem still persists, but very encouraging to see that there's an increasing body of evidence that shows that there are risks still in the cold chain that need to be addressed, and that helps us kind of give concerted action and attention to it, and hopefully the technology with respect to the freezing side will soon catch up. So on that note, Debbie, may I invite you to lay out the next 3 presentations for us?
Turn this one on. So it's on. Good morning. Less is more this morning, so I'm going to be quite brief to keep things moving. But we're about to hear from the experiences of 3 ministries of health with innovative equipment that is really extending the ability of the cold chain and facilitating outreach. We'll hear about the passive long holdover device or vaccine storage device, and we'll hear about solar direct drive, and we'll hear about the experiences in Togo in taking Menafrivac vaccine, campaign use of that vaccine and storing it in a controlled temperature chain, storing it at ambient temperatures up to 40 degrees C for up to 4 days to really help ease logistics and extend outreach. So the main thing I want to say is that we're really indebted to these immunization programs for their willingness to be early adopters and assessors of new equipment and new approaches. And we really look forward to learning from their lessons and their experiences. It helps not only to improve the equipment, as Denny said, also to improve the approaches, and it informs our training and our introduction. So thank you.
Great. Thank you very much for that segue. So may I please invite Dr. Gomis from Senegal to the stand?
Good morning, everyone. I am Khadidiatou Gomis, National API Logistics Officer, Ministry of Health, Senegal. I am Francophone, so please excuse my English. I am pleased to share the experience with the passive vaccine storage device used in Senegal. Listen from using long holdover passive storage device at the mine. Always in the search of solution to improve the cold chain in the most disadvantaged area, Ministry of Health, in partnership with PATH and Global Good, have experienced a device without a power source that can keep vaccines at the correct temperature range for at least a month. We will quickly see the presentation of the device and the history of its design. At the left, you have a global view of the device, and at right, there is how the device looks like today, and you have a global view in left. It is a result of an evolution that has integrated the inputs from user and technician. And you have on the top a screen for different temperatures and any potential alarms, a USB port on the right for collecting temperature data, and at the left, the location of the battery which powers the electronic component. And we have 5-liter vaccine storage and 8.6 kilogram for ice capacity, and the total weight is 45.8. This is the interior view with the location of ice packs in blue. We have a vacuum system around and the conduct to the opening. On both sides, you see ice packs, and between are 3 columns of racks where vaccine will be stored. Remember that the vacuum space serves as isolation that keeps low temperatures inside the device for a long period. And we have here studio description in 2011, and the study have 2 phases, and the objective of the first phase is to evaluate the duration and temperature hold time of the passive vaccine storage. And we had 6 sites from February to April 2013. And the objective of the second phase is to conduct a comparative evaluation for a fully burdened cost and performance for deployment of a passive vaccine storage device in static and mobile vaccine delivery setting in Senegal. And we had 12 sites from December to July 2014. We have criteria to select a site. And the criteria are power availability. The head post could not be connected to grid electricity or undergo recurrent power cuts. And about population, the population covered by the health post should not exceed 6,000, which would represent a target EPI population of 250 children and corresponds to the 5-liter vaccine storage capacity on the device, including the new vaccine. For connectivity, the health post had to have telephone network coverage to help supervise the operation of the device. For human resources, the health post staff had to be highly professional and committed. Management of freezing, the health post had to be located in a district where the supplying warehouse in the one region and regional pharmacy in the second. When the supply could manage the ice pack freezing process. And for transport, healthcare workers had to have transportation, public or private, enabling them to transport the device. The results for study 1, phase 1, we have major goals were met. We have no broken vaccine vials, no frozen vials, and no change in thermal performance seen in the behavior. There were minor issues. We have minor spoofing, shows at 1 in the device, and a broken stack handle shows in 2. Whole time result for 5 devices in Saint Louis region. We have monitoring the temperature in warmer region. The temperature of day are from
5 minutes.
43 to 25, and in the colder region we have 32 to 15. And in warmer area, the whole duration is 38 days. In colder areas, up to 56 days. Study phase 2. In study phase 2, we experienced 2 systems, pull systems and push systems and push system. For each system, we have mobile strategy and fixed strategy. For pull model, each month, it's the team of the district office which provides transportation, deposits the P6 already conditioned with ice packs, and the stock up of vaccine. That is in mobile strategy. For the fixed strategy, the P6 is not moved and these are just the ice packs which are transported to the health post. For the other model, the push model, it is a nurse who carries the P6 to the district to change it with another one already conditioned in the mobile cage. Or they are the ice packs. That are transported to be changed in the fixed cage. At the same time, he took the opportunity to stock up on vaccines. The whole time results, this chart was recorded in an arid area and in a hot season. You have the charts of max and mini. We see that the temperature do not exceed 3 degrees after 45 days. And description of test, we have 6 health posts, 3 in fixed strategy, and the 3 others in mobile strategy. We have health post equipment, regional pharmacy equipment, and a pharmacy regional team, and of course monitoring system. In the other region, that's the same. We have 6 health posts, 3 health posts in fixed strategy, and the 3 others in mobile strategy. Wastage result, and we have 12 sites. We had the population, and there was no wastage related to the use of P6 reported during the study. And this is the user experience. They give their opinion about the device. We have adds comfort. The device helps nurses in their daily immunization activity. It's easy to clean, no defrosting work, etc. It's easy to use. Findings show the device is easy to use and help nurses in their routine work. Temperature is easy to monitor, no maintenance. Vaccine vials are easy to pack. Power cut issue, no more worry regarding saving vaccine during current power cuts. The space for storage is, the unit does not occupy too much space in the health post, and never out of order because it is a passive device. Only the electronic system can fail. However, the capacity of the device is insufficient during immunization campaign, and the solution is to use during the campaign all the P6 in the district using to mobile strategy. And there is no possibility to put all the temperature sensitive product in the P6. I think that is not something negative. The weight of the device, heavy to carry for outreach. In this case, it's recommended to use the old system who is to bring vaccine carriers. And in conclusion, this is long-range new passive vaccine storage device carries a lot of hope to solve problems in areas where electricity is unstable or absent. It minimizes recurrent maintenance problems of the cold storage equipment, and therefore provide good solution to answer that continuity of the cold chain everywhere. I thank you for your attention.
Thank you. Let's move on. Dr. Cuong.
Good morning. I wanted to share some experience from the EPI in Vietnam related with the solar direct drive refrigerator for store the vaccine in EPI. So I will talk about the Vietnam and EPI in Vietnam a little bit, and I'll go for this.
Dr. Cuong, can you bring the mic closer to your mouth, please? Take the microphone closer to your mouth.
Okay. Yeah, I will talk about the Vietnam and EPI a little bit in Vietnam. Our goal, health system needs monitor size in some refrigerator in Vietnam. Related with this, result, accept and feasibility, challenge and lesson learned, and also conclusion for this. So Vietnam is we have the target children under one about 1.7 million, and that means the number of the vaccine in EPI must lost for every year. And also for the climate, it's quite different between north and south. In the north, we have the winter and rain, and in the south, it's hot. It's very hot sometimes. And so that's why if related with the user solar direct driver, it will be, might be different between north and south. And also in Vietnam, we have a 5 level to related with EPI, national, regional, provincial, district, and commune. In that case, we have a lot also a kind of equipment in different level. For this, our goal is assess a variety of the solar direct driver technology for storing vaccine in different regions of Vietnam with regard to equipment performance and available of solar energy in Vietnam. So what we need for this? Related that is a problem is the temperature for store the vaccine is from 2 to 8, and also about the unavailable of the power condition. And previous solar vaccine refrigerator was very expensive, and the battery used for this was very large and costly for the maintenance. So that's a problem when we do this. And we expected about the direct drive solar refrigerator and store energy in the form of ice in the cooling system. We use 3 kinds of the refrigerator here. Is the show sheet for the vaccines refrigerator store. And we use 2 other one from the domestic. And for the first one, we use it with the support from part to do this. And for domestic, we use outside with the support from the company when they wanted to try this kind of refrigerator in Vietnam. You can see here in the first part, we use it from the solar scene. You use 2 parts, north and south, and from the domestic, we use also north and south. And here we can see here for the solar scene, we use for more than 1 year for 2 other one. From the domestic, we use it in since last year and this year. So also the reason from what we had to do for this. Related about the solar chain, the first one, we have the good temperature for store the vaccine. It's from 4 to 5, quite good. If you compare, it's 2 to 8. We often is 4 to 5 for a long time. And however, this one, I can go to detail later, but however, it's a good temperature, but inside it's very wet, so it will be make more detail later about how to store the vaccine in it. For the second one from the domestic, we have the very good one, I must say that. Also, here's this one. We use TCW 2000 solar direct drive. They had 2 parts. One is for the vaccine, and the other one, the freezer for the ice pack. We put it in one in Hanoi, and on in the north, and on the other one in the south. Here is the outcome from this kind of the equipment. So we have the temperature between the 3 to 5, something like that. But it's a different, quite different day and night, you can see here. You compare with the same kind of the equipment, use electric, the one is below. Not very quite different between the temperature high and low of this. So I think that it's very, it's easy to understand why different between solar direct driver with the electric refrigerator. That's here is in the refrigerator box for the store the vaccine, and the other box for the ice box, that freeze box is also very, very different between the temperature day and night, and even in the night, the temperature more than 0. So that's why if you talk about the freezer is for the store of vaccine, it's not possible. But for the ice box, might be good. So we also compare with this kind of the equipment use electric, so it's also very different. So for the other one, so this one is TCW 40. So this one just used only for the store the vaccine, no for ice pack. So it sounds good here. The temperature also is good between day and night. It's about the 3 to 5 degrees centigrade different. And the inside of the refrigerator is good enough for store the vaccine about the temperature and also about the wet inside, no wet inside. Compared with the first one, it's very wet inside. So relative it's a technical issue for this kind of equipment. We think that the solar refrigerator is this one. Sometimes it has a broken during the time we use, and for that one, relatively
5 minutes.
So relatively that the engineer must come from the company to correct it. And the other thing is relative is pneumatic. I think that it's good because for the sound in the hot weather, but it's not good because the temperature is not below the temperature for this kind of equipment not below 8. Yeah, it's often more than that. So relative it's what we expected and feasibility of it. This one, I think that we can store the vaccine. We don't worry about the freezing temperature, yeah, and you don't need worry about the have to pay for the electric cost. And relative it's yeah, but for the solar machine, the temperature is good, but we cannot use it because of the wet inside of the refrigerator. And also, we can say that for the different and scales for the climate is not easy for users this kind of equipment, but in the south is fine. And related the challenge for national for it. Yeah, I also mentioned before, is the vaccine in this kind of equipment, solar chain, I mean, is wet, so we cannot store the vaccine inside. It's the problem with the vaccine and also the box outside of the vaccine. And for the, we try to do with it, but it's not passed because we try to put it in the plastic box, but it's not good enough to do. And relative is the technical support. It's a new equipment, so sometimes it's very difficult to correct it if something happens, especially for the first one. And for conclusion, the pneumatic refrigerator solar direct dry can use for store the vaccine, and we store already after 6 months dry. And for the other one, solar chain is not cannot use for store the vaccine because they're very wet inside. And also, if you use this kind of the equipment, you don't need to pay for the electric cord. I think that's good. Thank you very much for support from PATH for this, and also for some other company for this. Thank you.
Thank you, Dr. Cuong. So we've just heard two very different presentations. One, Dr. Gomis with a pretty positive experience with a long holder or passive storage device, and then a more mixed experience with the Churchill and the SDD. So let's see what Dr. Landoh will tell us about the strategy for CTC. Maybe it'll be somewhere in between.
Thank you. I'm Landoh from Togo. I'm working for WHO country office. I'm here to share with you the experience from Togo in the implementation of Men-Afrivac campaign using the controlled temperature approach during the period 28 November to 7 December 2014. For those who never been to Togo, Togo is a country, a small country located in the West Africa, in between Burkina Faso in the north, Benin in the east, and Ghana in the west. So the total population for the country in 2014 was about 6 million. And for the campaign, we targeted to vaccinate all the population aged between 1 to 29 years old, which comes to 70% of the total population. Notice that the country counted for 6 health regions, and only 4 were more at risk for meningitis, because those districts are close to the meningitis belt next to the Burkina Faso. For the 4 more at risk region, we have 28 districts that were included in the campaign. The average temperature for the Togo is about 36 degrees, going from 22 to 39 for some months. For the epidemiological aspect, every year we have some meningitis cases that have been reported in the districts, and we have experienced a lot of outbreaks, and the large outbreak reported was in 1997, which caused almost 1,000 cases and almost 200 deaths. For the Men-A campaign, I've said that 28 districts were targeted, and of the 28 districts, 10 were experiencing the CTC approach. For the 10 districts, the total population were about 1 million persons. This map shows the districts that have been included in the campaign. The districts in pink were using the CTC approach. The districts in green were not using the CTC approach, and those in blue were not included in the Men-Afrivac campaign. For the CTC district, 3 scenarios were implemented. We have the scenario 1, which was applicable for health centers where these health centers don't have a cold chain. And also for those health centers, their district center got a low capacity to produce ice pack to support those health centers. For the scenario 2, this scenario was appropriate to health centers without cold chain, but their district center got a good capacity to produce ice pack to support health centers when implementing the campaign. For the scenario 3, it was applicable for health centers with good cold chain and functional cold chain in those health facilities. The preparation process was again in all the districts implementing the campaign, and it was supported by partners like WHO, Gavi, and UNICEF. And each CTC district determined the scenario, the appropriate scenario for each health center to be implemented adequately during the campaign. We also trained the stakeholders and field workers on how to use the MEN AfriVac vials and how to apply the CTC strategy. For the coordination, we put in place a national committee in charge of the overall coordination of the activities. And in this committee, we have subcommittees such as technical subcommittee, logistic subcommittee, communication subcommittee, and pharmacovigilance subcommittee. We have also acute event following immunization expert committee, which was in charge of reviewing the cases, the IFEs cases that have been reported, and afterwards they have classified those IFE that have been notified. In each district and region, we have also coordination committees which are in charge of the whole coordination in their level. For the implementation, we use 3 strategies. For the first post, we targeted to vaccinate about 60% of the target population. And advanced post, we targeted to vaccinate about 30%. And in mobile strategies, we targeted to vaccinate 10%. In CTC district, about 24 health centers use the scenario 1, 43 use the scenario 2, and 101 health facilities use the scenario number 3. Supervision activities were conducted by supervisors from national, regional, district, and health facilities level, and technical and financial support we got them from partners, WHO, HQ, Afro, EST, and country office, as well as UNICEF and Gavi. We put in place also a system to collect daily the data, analyze them, and transmit to the upper level. And also we organize meetings, coordination meetings at the district and regional level, as well as at the national level, to monitor the evolution of vaccine coverage. After the campaign, we implement also rapid assessment and external vaccine coverage survey, which was conducted in March 2015. This picture to give you the commitment, the high commitment during the campaign, because the campaign was launched by the president of the country, and we got also the participation of the WHO representative and UNICEF representative, which is a good idea to support the campaign in the country. For the result aspect, we found that the administrative vaccine coverage was good. It was 11%, 100% in Plateau region, and the high level was 106% in Kara region. When we got the assessment, rapid assessment, it shows that the coverage went from 97% to about 99% in some regions, which was the same finding for the external survey. When we compared the CTC and non-CTC districts, we found that the administrative coverage was about 102% in CTC districts and 101% in non-CTC districts. For the survey survey, these findings we found that 97% coverage in CTC district compared to 98% in non-CTC district. For the supply management, this slide to show that peak threshold temperature indicators were included in the supply management in CTC districts. The number of doses, vial doses used in CTC district was about 1 million, and the vials, 2 vials were discarded due to 4-day uses, and the number of discards due to temperature exposition was 0. We notified less acute events following immunization, and most of the IFEs were minor. And when the National Committee classified them, of the 33 severe IFEs, we found the expert committee found that none were attributed to the use of CTC. What are the lessons learned? The commitment of the political and religious persons, the high supervision for the campaign, especially in the CTC district, and we found that to bring the success for the CTC strategies, we need macro planning at the beginning, from the peripheral level up to national level, which is good to determine which circuit or which scenario is appropriate for which kind of health district, according to the availability of cold chain and the distance from the district to the health facility. We found also that the coverage was similar in CTC district and non-CTC districts. What is good also is that during the regular regional coordination meeting and district meeting, we can continuously or daily monitor the evolution of vaccine coverage. We found also that there was no significant difference in vaccine wastage in CTC compared to non-CTC areas. And we didn't experience a lot of IFEs, and most of them were minors. But the bad experience was that at the beginning of the campaign, the stakeholders were they were afraid to keep a lot of vials due to the fact that they were to the wastage. So at the beginning, we got difficulties to bring up the stakeholders to adequately implement the CTC. So the scenarios were not adequately implemented at the 2 first days of the campaign. But the supervision and the coordination come up to resolve those issues. We have also good acceptance of the stakeholders and their enthusiasm to use the CTC in the country. We found also that in CTC districts, the management of ice packs was not a concern because we use very few ice packs to move vials from the district level to the health centers for the health centers that are using the scenario 2. One vaccine carrier is sufficient for each team compared to 2 vaccine carriers in non-CTC districts. And what we try to show also is that during the polio vaccination that we conducted 2 weeks after the meningitis campaign, the districts who have used the CTC approach have adequately and properly used the cold chain strategies without any confusion. In conclusion, we say that the requirement for good implementation of CTC are the commitment of decision makers, the adequate planning, the adequate staff training, and also strong supervision and monitoring system to be in place in each district and each region. And we found that scaling up the CTC strategy to other vaccines would contribute to overcome disparities that have been shown since Monday in some countries such as Togo, where we have difficulties to come up or to provide health centers with adequate cold chain. And if we come up to that level, we'll be happy that all those children that you are seeing will be happy to thank you and say merci.
Thank you very much, Dr. Landoh, for bringing us back up and showing us that innovation can be very positive. It's a very promising approach. I think everybody in this room would agree with me. This is probably one of the most landmark innovations that EPI has dealt with in the past decade. So it's pretty extraordinary. And we have not just meningitis now, but we have pneumococcal that's been approved for CTC approach, as well as cholera vaccine, and some promising approaches perhaps for HPV as well. So it's pretty fantastic. Thank you to all three presenters also for sticking for time, as well as really enriching the discussion for the rest of the day. So before we move into question and answer, I'm probably going to make an unpopular choice because we're running late. We're going to limit question and answers to just 10 minutes. We can maybe take 1 or 2 questions. But I want to reassure you, if you look at your conference program, I'd like to pull out and highlight a couple of points. For CTC, there's a session from 4 to 5 o'clock today that Dr. Landoh will be present at in the ballroom. For the solar discussion, to go more deeply in that, there will be a discussion today from 2 to 3 o'clock in the New York room, which is just downstairs. And for the temperature monitoring, there will be further discussions on temperature monitoring from 2 to 3, and again from 4 to 5 downstairs. And I also encourage you during coffee breaks and lunch breaks to go specifically to the speakers if you want to go more deeply. So I'm not trying to, prevent you from engaging in discussion, but I have to ask in this plenary that we limit to just a few burning questions or clarifications that you'd like to raise. So with that, can I pass over to our moderator?
Thank you, Diana. Coffee and bathrooms just a few short minutes away. Questions. So microphones are out. Let's take, can you raise your hand so I can see who has a question? Tom up front here. We'll do 2 questions. And Solo.
Thank you. I would like really to congratulate all the presenters for excellent presentations. And just recall at the beginning, the first day or at the opening, Raja said something. What was to me very interesting. That was, if you can make it simple, but if you have to, make it complex. And I think that this is really the context I want to highlight it here by trying to match the presentation from Denny, Ben, and the country presentations. From Ben, we say that the requirement for cold chain is the temperature monitoring. Especially for the refrigerator, the 30 days is a minimum today. While Denny presented the specification, I haven't seen that in the specifications. And I think that this is one of the points we are missing. For Khadi, she presented a device at the peripheral level that are combine these two. So you can have the temperature and you can even download the temperature from that device. And I think that the specifications, if I could, then I will call that we include systematically in the specification of the equipment, refrigerators, these continuous temperature monitoring devices.
Thank you, Solo. Tom? Yes, please.
Hi, I'm Tom Lewis from Remontis. We make temperature monitoring equipment, which is very complex, which we try to make simpler. But we do need feedback from you, and I'd reiterate what Benjamin Schneider said, that we don't want to design in a vacuum. We want to design something that you can use in a system. So I would appeal to you to let us know, preferably the good bits, what you need to see. Thank you.
So far we're looking for questions. These are good ideas. Thank you for bringing them up. Sir, please.
My request is for Dadja. I'd like some clarifications. I saw in the year 2013 and 14, there have been a few purchases of absorption equipment. My understanding was all procurement through UNICEF have to be only PQSP qualified. Thank you.
Dadja? Yeah. Did you get that?
Would you like to answer now, Dadja?
Yes,
okay.
now?
Yeah, please.
Okay. Okay, with regard to absorption procurement, I think it's a valid question. First of all, we need to know that all equipment that UNICEF Supply Division procures should comply with PQS. So that doesn't necessarily mean that all equipment should be listed with PQS. It is known that there is no absorption refrigerator that is PQS listed. But as you may know, there is a specification and a testing protocol within PQS for absorption refrigerator. So actually what happens is whenever countries request for absorption refrigerator, maybe there might be some country here who might be the one who requested for absorption. We don't just buy it like this. We really get back to them and ask them, are you really sure? We have to get a kind of justification letter from the Ministry of Health, not even from UNICEF country offices. But you know, there are some countries who really want to procure those things. And of course, there are specifications and there are testing protocols. So with that testing protocol and especially specification, we use those specifications to procure not PQS, but of course PIS products. That's how, no matter how small it is, we are still procuring these absorption refrigerators.
Thank you. We were handed a question. Denny, this is for you. What qualifies as a temperature excursion in terms of time and temperature?
Sorry, repeat it.
What qualifies as a temperature excursion in terms of time and temperature from a PQS specification?
Alarms.
That's what we were talking about yesterday.
So if I understand, the question is about alarms. So what alarms to be used? We have set some alarms for international shipment, alarms for the 30-day temperature logger for refrigerators. Those alarms are set in accordance with the thermostability of the vaccines. So we have set a kind of model to determine what would be the most suitable time and temperature to set the alarm, so it would give enough time for if there is any failure for action to be taken and respond to the problem. So that's how it has been set. What can I say more?
Nope.
No, I think that's
Okay.
the reason.
Brigu?
So hi, I'm Brigu. I have a question for Dennis, and this is regarding, one part of the WHO PQS is qualifying the devices, whereas the WHO PQS also does performance specifications out time and time for ILRs and defreezers. And you very well know that many countries who do their domestic procurement take these specifications as a kind of Bible for doing their own procurement. Okay. Now the problem is that the technical specifications that are available with WHO PQS are of such a wide range that the devices available. So while making choices, the country doesn't have too much of an option to look in for. So I think if you might consider, it's time to better guide countries in doing different kinds of procurements rather than a single type of specification based that creates limitations, because countries procure based on the price. So specifications come from your side and then the prices come, but that specification range has all sorts of devices that come in. So do you think you need to create a little more kind of compartmentalized or more specified areas or focus upon, so that countries can then refer to these are the specific requirements, these are the PQS specifications available?
So I think your question is about honing in on the environmental conditions in segmenting up the PQS, is that correct? Denny, do you want to take that?
Yeah, I suppose you're right. I mean, we have tried to have specifications that would answer all conditions that we find in countries. So, I mean, there is no fridge that can answer all the conditions in countries. So that's why we have variety of documentation. I mean, I don't know if I'm answering this question. Huh?
Yep. Brigu, did that get to your question? Okay. I think we have time for one more. Amadou, can we take yours?
Yes, thank you, Pat. I have a question for Dadja. In your nice presentation, you mentioned about the supply lead time, about the cold rooms. So I was thinking if you could give us an idea, what is the supply lead time about the ILRs and then the SDD refrigerators? In addition to that, I just would like to make one comment about your response to Sham. It's about the Gavi HSS. So if countries are procuring equipment with the Gavi HSS, according to our new guidelines, the equipment have to be pre-qualified. So at least the SD should pay attention given where the funds do come from. If they come from Gavi, they have to be PQS, according to Gavi HSS guidelines. Not PIS, but PQS, which means right now, no absorption refrigerators can be purchased from Gavi HSS money, but when an absorption refrigerator becomes PQS, the Gavi HSS or Gavi resources could be used to acquire those, but not currently. Right now, no. Just wanted to clarify that. Thank you.
Sorry, can you repeat the second question? I didn't get that one.
I was saying, what is the supply lead time from when a country requests for SDD? What is the lead time up to the equipment installation in countries, given your experience to date? Thank you.
Okay. Okay. With regard to lead time, I think maybe this time around, especially for solar direct drive refrigerator, the cost and the lead time is now public as of, I think, the day before yesterday. I can share with all of you the link that you can go and get the price and the lead times. So since we have an LTA on SDDs, the lead time will be shorter in comparison to having non-LTA procurement of non-LTA products. So this time around, I think it's public. You can get the price and the lead times openly. Thank you.
Time? 20? Yeah, okay. Thank you.
So apologies, regrets. I see some hands still up, but we'll have to put a close to this question and answer session. We will have another round just before lunch break. So if it's still a general question, you can pose it then. So what I'd like to ask is that we all come back at 10:45 promptly. And during the coffee break, if I could also invite our speakers from Laos, Mozambique, and Turkey to get up to the panel at the end, and we can start promptly at 10:45. Thank you very much.
It's difficult to hear.
are both. Not the other Osman.
Let's all take our seats, please.
Bana 5 dakikada bir haber verir misin? 5 dakikada bir. After 3. 5, 10. Süre. Lao is sunum yaparken. Just go ahead. Go ahead. No, go ahead. Well, let me just say one word. Yeah?
Great, thank you very much. I have a couple of announcements before we get started. So we are going to end this session on time at noon because we, as you know, have a kind of a domino effect. If we're not on time, it affects the afternoon sessions. So I again will ask all speakers to stick to time, 12 minutes. The request is for the speakers to know that, reminding us all that we're actually live streaming. So in fact, all the mics are on. So when you speak at the podium, you're obviously being recorded, but in fact, the panel is also being recorded. So please, if you need to speak to your neighbor, to not be near the mic when you speak, because it's actually being recorded as well. Secondly, to highlight for everybody that there have been panels placed near the Secretariat, big wall panels, which will post daily announcements, fun things to do, and already I see that KDC, the events organizer, has put up a list of suggested activities that you can do in Bangkok, places to eat, things to see, a panel for important announcements, and a panel for ad hoc meetings. So this is in fact for you, the participants, that if you would like to pull together a think session or a coffee meeting or a breakfast meeting on a particular topic, please feel free to just put up a post-it. KDC at the Secretariat has post-its. Just write a little blurb on that and stick it at the ad hoc meeting panel. So it's a different way for us to also just keep connected and communicate. And then before I pass on to the next three panelists, I'd actually like to invite Dr. Cuong to just say a few words. I think there was some remaining threads from the previous session we just had, and we just wanted to clarify an issue. Please.
Okay, thank you. I also don't have a chance to talk more about the refrigerator from the True Energy. So now I can say that we use a solar direct driver. That one is the first one. So we had a lot of the problem at the beginning. As you know already about the good temperature for start vaccine, but very wet inside. We also try to, our best to try to use that one for start the vaccine, but still not pass because we put it in the plastic box, but it's still wet and not easy to start the vaccine. And also we had to inform to the company, and also relatively that at the beginning sometimes it's broken. Yeah, at the 2 times for 1 year. When it's broken, it's not only the people inside country can use can correct it. We must waiting for people from outside and take time for them that. So in that case, we all read about the using that one. However, we had to work to talk with the company, and we believe that they also have to do some other one. Based one off, we had to problem in the past. So I think that at the beginning we use that one. It's not good, but it's good for prepare another one instead of the first one. We don't think that the first one can use that is good, but we have the experience from that. In that case, it's good. And also I mentioned about another kind of the equipment from domestic. We use that one with the experience from first one. For the second one, we clear to understand that it's good for start the vaccine. And I hope that from the True
company in the future they have another one to better for store the vaccine. Oh, thank you.
Thank you. Okay, so just to close the loop, so the idea was to make clear to all that, you know, with this equipment, we need a cyclical kind of feedback mechanism. And so the whole idea is to actually gather these kind of field experiences. Denny spoke about that in his presentation on PQS, to then help feed back to manufacturers on how things you know, work well or where they may actually need improvement, to then continue that cycle. So that was Dr. Kung's point, and want to remind people that on the TechNet website, in fact, we have an equipment review page. We've had a number of people comment on that page. Kashem, I think, Serge has made comments, and that's the kind of things that we need at global level. We need to know what you see in the field and how things can continue to be improved or how we optimize performance from the equipment. So just want to remind everybody to take the time to give feedback on that website when you observe things that you think would be of interest. So we're going to shift quickly. I'm going to open the floor for Benjamin to set us up for the next 3 presentations.
Yeah, welcome everybody. The next 3 presentations are 3 country examples of how countries looked and then implemented temperature monitoring systems. How they, it's really not focusing a lot on the device. Devices will be mentioned, but I think the idea is behind, it's about a system where people react to the data that is being generated. 3 very different approaches. 3 different countries, and I think it's also showing to us, or will show us, that any solution needs to be very tailored to the country needs and to the country context. So we start now with Laos.
Good morning again, gentlemen and ladies and gentlemen. Firstly, I would like to thank for the give the opportunity, this opportunity to share some what we doing in Lao PDR. Lao PDR is our total population 7.5 million. We have we reach about 920 health facility, 17 hospital province, and 145 district hospital. For the EPI, EPI is a flagship program since 1986. That are 2 provinces, Vientiane Capital and Savannakhet province. Then one of the unique challenge is a limited information flow in our network. This limited give birth to the innovation I am going to share with you. Background: how CCIS was born in Lao PDR. Consent information system was born with the central idea of break to the bottleneck list here. EVM result show that temperature monitoring week, UNICEF and WHO provide 30-day temperature record to improve temperature monitoring. As the flow of the information is very limited due to organization complexity and new organization structure, we are therefore audit with inventory. As a result, repairs were delayed, parts not available when we need them. Also, distribution has been affected. We do not always get the balance stock of vaccine received to adjust the supply quantity. Finally, health workers overburdened by so many things that are too many forms that they must fill the data. We were looking for solution when UNICEF came up with this innovative approach of designing an information system using SMS as means of communication. Part give us support in data collection tool and backend software developed for CCIS. CCIS was conceptualized in 2013, and 2 years down then we made significant progress. That CCIS Kongxay information system. The data flow of CCIS standard form, health worker inform of monthly code SMS report where they report alarm and stock data. Of vaccine in single SMS, they can also send emergency messenger to update the function status of refrigerators. Report stock out and report need of replacing 30 TDR. In return, health worker get automatic acknowledgement form system. Technician and supervisor get notice of the Kongxay failure. Staff at one level up receive the stock balance of respective sign. The DSIS2 based CCIS model act as hub between health worker, supervisor, technician, and vaccine handler. The data and information and also be accessed to the dashboard on CCIS website. The data and information can also be accessed through the dashboard on CCIS website. In addition, monthly notice are sent to SMS. That's health system strengthening and health and DSIS2 with CCIS that we can show for this the structure. Linkage with EVM IP. The intervention to CCIS result few critical EVM improvement. Using CCIS, we are able to establish online inventory of refrigerators. Free status is updated using SMS from health worker. Alarm raised or not. Both are concentrate indicator of temperature monitoring. Health worker use 30 TDR for monitoring their freeze and with report every month. Awareness, surveillance, import. Getting the right information. I skip. Okay, this systematic use of 30 TDR. We train health workers on two. One on interpretation of free text. We train them how to code the SMS for monthly report. We train health workers in taking correct action in case of alarm and temperature execution. Supervisors were trained in providing support supervision and evolved the system brought to the judiciary for reporting any information reached by people on time, breaking to the bureaucratic network. SMS communication, this data put the system by health worker. This is example to how to code the simple SMS. Health worker read the freeze tag from freeze and count number of the heat and number of freeze alarm one time per month of every month. He then take the physical stock balance of all the vaccine and use the single digit alphabet for each vaccine and combine the text tool for and form and SMS. Health worker then send the SMS to central number which transmit the data to server. Receiving phone identify the location with phone number of person sending the message. The advantage of system is very low cost, low time consuming at health worker end. SMS communicate information for user and decision maker. As you can see, the system provides information to rank of the staff from sending automatically acknowledgement to sharing around with technician and automatic update of content, function, status, and stock balance for taking smart decision on the what quantity to send. That this is for the dashboard and data visualization that question-based performance system to be linked to the DHS2 CC module. I will not go into detail, but there is snapshot of view we get with database, which is still under construction CCIS. Aim to explore the function of the SS4 sorry, nearly finished. Then now we look some of the data from prior implementation, field observation, number of alarm go down after one round of reporting. New alarm keep coming up, different sign. What happened? Finally, the most important learning from project 100% complaint of site sending SMS. This shows that health worker would respond with data if reporting made easy for them. In this case, please note that it's cost health worker money to send SMS, but it was not being as programmed. That means they use the mobile phone, the budget. Main sharing. Finally, before closing my presentation, I would like to share the key challenge we face with the projects. Programmatically, the CCIS gave us fantastic outputs. We get information without effort. But the technological, we face some challenge. We wanted to use tablet for training for expansion of project, but the information technology joint taking long time to implement. Training pilot sign one-to-one is different task, but rolling out nationwide is another challenge with using ICT tool. We face some challenge in using the right language for SMS communication. Finally, we settled down to use karaoke, English script and SMIC for the send SMS. Lesson learned. The introduction of Tier 3 DTR, that means the free stack, has been very successful. It kept confidence to health workers on performance of their freeze. It made useful information sharing very easy. Give time to prepare for nationwide expansion. Carefully select on of the technology. Note that easy option, especially when we do not want to create software parent reporting stream. With this, I thank UNICEF. This on for this opportunity. Once again, we thank UNICEF for supporting us in Lao PDR in doing this innovative work. Then thank you for the UNICEF that actually the Thai by Thai to need to for the Lao that improve the not only monitoring temperature system, but art technology or some logistics. Thank you very much for your attention.
Thank you very much, Dr. Kongxay. May I invite our next speaker to the table? It will be Ruth Bechtel, who is in fact replacing Dr. Graka, who couldn't make it because of visa issues.
Good morning. Once more, I'm back to present on behalf of BRASA, Mozambique EPI manager who didn't make it here. And this time I'm going to talk about remote temperature monitoring, results of a randomized controlled trial that we did this past year. What is the context in Mozambique? The standard operation procedures require twice daily temperature recording by the health facility worker. But what we see in reality is that adherence is not reliable. So temperature is not always recorded, and if it is recorded, it is not, sometimes it's not accurate. So the little data is collected and analysis doesn't happen. And twice daily thermometer recording presents many opportunities for missing excursions that happen in between and could lead to potency issues. Maintenance practice also is weak. There's weak maintenance plans in place. While there are technicians, one at each province that supports the health facilities and the districts, often they don't have spare parts or the transport to go to do this maintenance. And also the different types of cold chain equipment that are in the health facilities also present a challenge for maintenance. The EVM, on the other hand, identified and made recommendations to these issues. It recommended that temperature monitoring devices should be installed in cold rooms and freezer rooms. They should also be recording
record keeping and filing should be established, and temperature recording also should be done, and review processes should be in place. The EVM also recommended that we should also establish a maintenance recording system for the cold chain equipment. And SOPs should be put in place for preventive maintenance. And then the people at the health facility, the healthcare workers who are using the fridges, and the technicians should be trained. So the remote temperature monitoring device presented a unique opportunity in Mozambique to study improved temperature monitoring approaches. And we did this in partnership with NextLive, who provided the device, the cold trace device. This was responding also to a call from the global partners, such as WHO and UNICEF, for evidence that will be used to improve decision-making on cold chain temperature monitoring approaches. So using the randomized control trial design, we did this in almost 90 health facilities, and they were divided into 3 groups. I will talk about those groups in the next slide. A research protocol was prepared and shared between the partners, NextLive, UNICEF, and Village Reach, and also the Ministry of Health participated in that. The implementing partners for the trial were Village Reach, Ministry of Health, and the directorate, the provincial directorates of health. So the trial was looking into using different devices, one being the cold trace, which is on the far right, and the second group, the second device was the fridge tech, which is also known as the 30 DTR, and the thermometer, the STEM thermometer. So these devices were divided into these 3 groups that I talked about. The first group having the cold trace that would send SMS alerts, and these in case of temperature escalations. But the SMSs are also sent to the healthcare workers in the morning and in the afternoon, so that they don't have to open the fridge to read the temperature and report it. So they get the SMS telling them that everything is okay in the fridge in the morning, and it tells them again in the afternoon before they close. If in the case of alerts, if the temperature goes up above the recommended temperature range, or if it goes too far below 2 degrees, then an alert is sent to the healthcare worker first. And if they don't respond to that alert in a given period of time that was agreed, the SMS alert is escalated to the supervisor of that healthcare worker, and the escalation goes also to the supervisor of the supervisor in the event that both of them are not attending to the problem. So training was provided to this group about how this was going to work. The same thing with the 30 DTR, the healthcare workers in that group were also trained on the proper use of this and the proper recording and everything. Group 3 was more like status quo, and no intervention was done there in terms of training.
Excuse me, 5 minutes.
Okay. The results show improved fridge uptime with the remote temperature monitoring. So we can see the far right, group 1, had 86% uptime
and 3% temperature below 2 degrees, and only 11% above 8 degrees. And the others, group 2 showed 79% uptime, and group 3, 62% uptime. We also saw that with the remote temperature monitoring, the cold excursions were fewer than other approaches. So we had an average of 3 in the health facilities that were in group 1, and 6 in average for group 2, and almost 8 in group 3. And then the duration of the excursions also were different in each group, and we can see group 1 having a shorter duration compared to the other 2 groups. And the difference was pretty amazing in terms of how long the duration of excursions can be with the 3 different devices. So what actions were being taken to respond to these alerts? So at different levels, actions were expected, but on the top bar, you can see that you need to have, in order to have these actions and responses, you need to have the device that tells you that there is a problem. You need to have people that are trained, that are based at the health facility. You need to have the tools, the kits for repairs, where there's a necessity for that. So at the health facility level, the staff would, if there was an alert, they would open, they would defrost the fridge, they would adjust the thermostat, they would switch energy sources if they had an option to that. Or follow the SOPs that are in place for what happens when there's a problem with the fridge. They would call their managers and report, and they would perform the shake test for those for freezing exposures, and they would call the maintenance guy if necessary. The technicians would be able to do a preliminary diagnosis before they actually travel there, so they know what to take and what the problem may be. Sometimes they talk to the health facility person to help them resolve it without them traveling. They were able also to track the performance of the fridges because of the reports that they are getting and in the performance of each fridge. The managers were able to follow with about 40 fridges at the health facility level. They were able to inform the technicians if there were issues there, and if they follow up with their technicians if problems were not resolved. So there was a certain level of stronger supervision and responsibility and accountability involved there. And the managers would also be able to, or the technicians were able to turn on the generator, for example, at the provincial level when there was a problem with heating. So these are some of the testimonies that come from the people that are using this device. They are showing how it has helped them, mentioning how it has helped them in their different levels of responsibilities. I won't read that, but you can read it later. So the RTM, as we can see, the remote temperature monitoring brings advantages at every level. The healthcare, at the health facility level with the health workers, relieving them from extra activities of having to read temperatures and record them on paper. The maintenance staff are able to know what's going on and able to react on time. Supervisors are able to do their own supervision. They're able to get reports on real time, and they're able to follow up if problems are not resolved, because they will know. And decisions at national and provincial level
regarding cold temperature monitoring, as well as just cold chain equipment, has been facilitated through the data that comes out from there and the reports. And tracking power outages also has been helpful in order to decide which facilities have weak power in terms of electricity, and then they can recommend, for example, for solar equipment. And so these, in conclusions, we infer that lower freezing duration observed in Group 1 health facilities could be because health facility staff and supervisors in Group 1 were informed about temperature escalations through SMS and escalated alerts in real time, and therefore had the opportunity to take prompt actions and inform technicians when needed. The evaluation also allows the government to make better informed decisions about the performance and benefits of different temperature monitoring practice and technology. Remote temperature monitoring is a tool that improves reach uptime by empowering health workers and managers. It reduces the burden on health workers by providing a second hand of eyes. We know they are all very busy. Often in some health facilities, there's only one person taking care of everything. And when that is the case, temperature recording often gets put aside. Estimated cost of ownership of this is at $208 per year for each of the 3 years utility of the device. Compared to the price of vaccines that are in the fridge in a given time, that are estimated at about $226. The benefits, so considerations for the future of deployments from this trial in Mozambique. These are some of the questions that are arising between the partners that are implementing. Do the
Please
benefits
conclude
justify
quickly.
the cost? Do they justify this for national scale-up? In case of budget constraints, how can this be prioritized? Can existing staff at provincial level lead the implementation of this instead of hiring technicians that are going to make it more expensive? How can the case be made for including financial support for these types of systems at national level? We have seen definitely that these are very helpful, but can they be supported? Are there ways to reduce ongoing costs of SMS and data through corporate social responsibility for the companies, for example, that are providing SMS services? Can contracts be better negotiated? In Mozambique, we didn't get negotiated. We got the retail price. We didn't get negotiated price because the company also wanted us to be able to see what is the real cost of it, so that their own contribution in the future could be during if the device, if the project is expanded, then you'll be able to estimate what is the real cost that the company actually contributed into the project. Thank you very much. I tried to include a wheelbarrow in this presentation, but I failed. I hope you enjoyed it all the same. Thank you.
Thank you. And our third speaker, may I invite, please, Dr. Tarkan Yamanoglu, who's replacing Dr. Osman.
Good morning, ladies and gentlemen. In Thai, Savadi Kun. We would like to thank the committee, organization committee, for kind invitation. Thank you. Yesterday, second earthquake hit in Nepal. We are sharing deep sadness with them. Here we can see the Turkish map and flag. As you can see, and easily check from most of the world maps, Turkey is located in the center. Some information about our country. Capital city is Ankara. Population almost 78 million. plus about 2 million refugees from Syria now. Climate and infrastructures are variable by geographical reasons. Most of the infrastructures, roads, electricity, and internet connectivity is in a good position. Immunization schedule develops 6 antigens to 13 antigens. Our investments updated US dollar per year shown. You can see the decay of the investment because of the good organized competition between companies has the price decrease advantage. We have a 1.3 million newborn year, about 15 million doses per year, vaccine and anti-sera both. Except BCG and OP, all the vaccines presented as single dose packets. Besides childhood immunization program, we have adult, pregnant, and risky group immunization programs. Excuse me, this is not the last version, I think. Immunization supply chain depends on 4 levels. From the main store to promise centers, we have 3 months period vaccine supply. In other levels, mostly used 1 month period to supply the vaccines. We have all refrigerated trucks and vehicles all around the country. Why temperature monitoring is important for us? Some of the specs are especially depends on our country. Expanding volume, expensive vaccine in immunization program, no VVM usage. Both heat and freeze sensitive vaccines are stored together. Rigid alarm cutoff temperatures +2 to +8 centigrade degrees. Most domestic refrigerators are used. Cold storage boxes have WHO specs but not confirmed or registered yet. Mostly less knowledge labors, but the labors becoming more sensitive to temperature monitoring at the moment. We have a very complex health information system. It's also developing by time. The main vaccine tracing system combined with 3 modules: temperature control, stock control, and management modules. Sorry, this is not the updated and the last version of the presentation. Let me summary. The main idea was born 5 years ago. This is the second attempt to make the project to work. The first needed level is the QR code implementation. This is available for 4 years. Now we are able this year to finalize the whole system, but some optimization and evolutions are needed. But we also have time. Here is the building blocks of the vaccine tracing system. It's working on cloud-based cloud-based connection to users. A telemetry system building block between inventory and cold chain with the users. Telemetry inventory, email, SMS, and call center databases. Vehicle tracking is possible. Handheld terminals used to read the QR codes. Now it's ready to Android version, and iOS version will be available in a month. Also, the most important part is the integration of the whole system to the other health information systems. Some vaccine tracing system specification, it's tested for 50,000 telemetry device and concurrent access and processing for 20,000 users at the same time. It's a audible alarm option, offline temperature recording minimum 10 days, and also possible minimum 8 hours without any electricity. SMS and email capability, 7 days, 24 hours live call center we have. This is the most important part of the project. Maximum on-site support is available 8 hours.
5 minutes.
QR code based system, we are using some opportunities, also some smart opportunities. Here's a temperature monitoring system screenshots. There are 3 zoom levels, 3 different colors, meaning 3 different, three different meanings. Temperature list, temperatures can be seen, can be listed, graphic, exporting and printing options. Also, an ATS vaccine tracing system inventory tracking is possible online. These all data are online. We have a stand in the afternoon. We are happy to share detailed information and demonstration. Demo system is working online with real data. We have a call center. In call center, alarm management, risk assessment and management is done. Multi-level notification is possible and could be done and has an advisory function for end users. System managers, management is carried out by administrators, consultants, and engineers. We are joining at least once in a week. We are analyzing and checking the health of the system, whole system, do some brainstorming, devise solutions, and add the results to the job list timetable. The main incentives that we learn, there are many possible opportunities and possible defects of the system, and we can find the defects by the system easily and can repair and fix the whole system, cold chain, and vaccine shortage. We have, the list very changed for the last version. The main impact, we learned that written information is very important, education and training of the users and the third-party software companies is very important. Also, the belief in the project is very important. So it's not easy to develop such a system. Okay, personally, I have a last sentence. There are participants all over the world. I hope European and American countries may need encouraged to share their information and solutions with us. I hope in the next TechNet it will be available. Thank you.
Thank you. Thank you very much, Dr. Turkan, for that presentation, and our apologies for not having loaded the proper presentation. You recovered well, and I think your message, your key messages were understood. We will make sure certainly that the proper presentation is on the memory stick, so apologies again. Turkey actually was one of our host countries for the EVM training that we had back in 2013. It's actually one of the strongest EPI management systems, so we have a lot to learn from Turkey, and we really appreciate you coming to share the experiences. We have about 10 minutes for questions and answers, so I will hand over to Benjamin, the moderator, for that section.
So yeah, please, I will take two questions first. Please be short and to the point. So Alejo first, and yeah, you second.
Okay, thank you very much. Okay, so we have now the topic on equipping the system, and the way I look at it is still not complete, because most of the system that we are talking about is only deals with the vaccines as well as the equipment. But we forgot to equip the staff, which is a very important component of the system. I don't know if there's a topic later on that we discuss about that. Now for Lao PDR, okay, they have this SMS. It's very quick to collect information from the different facilities. But the problem here may lie on how quick you can get the corrective action on those problems. Thank you.
Okay. So I think the question was not about the SMS, was mostly comment. The point about tomorrow we talk about health workers, you're right, so, and the HR aspect. So next question.
Yeah, I have a question for the Lao about the 30-day temperature, the recorders. Because if I understand well, this kind of the devices have the limited the life for the use due to the battery. That is why I want to know if you have kind of the replacement plan for this device after the use of the 1 or 2 years later. Because if I understand the TechNet, because this kind of device, the battery should be replaced by only the supplier after 2 years later of the use. That's why I just want to know if you have any experience about replacement plan, or you will maybe conduct a replacement plan for the 3 days, the temperature recorders. Thank you.
Go, Ranjit, do you want to answer? I take one more question and then Ranjit will answer that question. One more question then. Yeah, Oleg.
It's a question actually open to the two countries. In both cases, your systems have generated alarms, and those alarms were submitted to some people. So what is your experience? First, what kind of alarms is worse to have? So what's about thresholds? What's about false alarms? And who are the right people to get those alarms? At what level? Is it important to know at the national level? It is not important to know at subnational level? Or it's most important to know just on the user side who manages that fridge? So how do you handle that? Thank you.
Okay, good question. So maybe I will ask now first Ranjit or Tawad to answer the first question about alarms, and maybe you can also answer then directly the question about the alarm setting. And then Ruth about also about how you set the thresholds and the
Thank you for the
clarifying the
question.
accountability for alarm responses, as well as here, Dr. Tarkan. Yeah?
So first I will go to the second question, the replacement of human, the 30 DTRs. Yeah? So yes, there is a plan for replacement of 30 DTRs. So first 30 DTRs was procured in Lao PDR in end of 2011. So those last almost 3 years. And end of last year and beginning of this year, Lao PDR has procured with the support from UNICEF another almost 1,200 FT2. And we hope that this FT2 will last another 3 years. But I would like to update you that this year, Lao PDR is finalizing comprehensive EBM improvement plan. And in this plan also, this was identified and budgeted for the replacement when it will be needed, maybe after 2 years. The first question was the real-time information, what we are getting, who is getting and how it is responded. So, as my presenter mentioned, that at this moment we are using this SMS system in 35 facilities. This SMS goes to the server, and immediately the health worker who sent the information get the feedback that thanks, we got your information. So these are the information we have received. They reconfirm. At the same time, that the central level, in the deputy program manager, he also got the information. And also it is notified to the supervisor so that they can take action. So what we could see last 6 months, that the number of alarm has been reduced. With this also, they report on the stock balance. At this moment, we are using for two antigens, for Penta and PCB. And also we could see that the managers at the district level and the provincial level, they could respond quickly. And now we could see there is less stock out of those vaccines. Our question is to Lao. Okay. Alarm experience?
The alarm settings, how did you, the thresholds, and how did you identify which people to send the alarms to?
So what I already mentioned, that this goes to the web-based, this is web-based, and the central level manager get the information. And at the same time, at this moment, what we are, our technical experts are fixing, that at this moment, the information goes to the central level. So central level, then they inform to the province and district level to take care. So in future, this will also go automatically get the information at the provincial level and district level.
Okay,
Thank you.
then I pass on maybe Ruth, if you can make some points, and then Dr. Tarkan on the last question.
So the question about alarms. The alarms go to the first level, they go to the health facility worker, the person responsible for the fridge at the health facility level. And like, as I said, she's then will react accordingly, like check what the problem is. The alarm will often say what the problem is, like it will say what is the issue, is it low temperature or is it high temperature? And if it is high temperature because of power failure, it also says that. And so they can go and check if the power failure is maybe because the fridge got unplugged or something like that, and they can resolve the problem quickly. Then if they are not responding to the alarm, the SMS goes to their supervisor, and the supervisor is at the district level, and it escalates also to the provincial technician and EPI manager if the district and the health facility were not, did not respond to that. So what we've seen is that this has made it results in better management and better supervision, something that has not been in place in the past. So people tend to react quicker to these alarms because it has given them a sense of responsibility because of the supervisionary aspects of the escalation of these alarms. But then there are also reports that are generated on a monthly basis that goes to the different managers so that they can see what is the performance of the cold chain equipment and what is the status on a monthly basis, so they have information that's updated. One thing that I just wanted to clarify that I realized I didn't clarify when I was talking about cost. The cost that I mentioned there is the total cost of ownership and not just of the device. So it's the device plus training plus all the technical support, everything that was incurred as costs during the implementation of this trial. And we think that it can be reduced by different ways because we have learned over time how to reduce the cost in the future.
Okay, thank you for the question, Oleg. The strictly adjusted cutoff degrees is the main subject of our country. We also have PQS certified devices in the same time, in the same locations. So the system mainly based to trigger an alarm before the vaccine wastage. We have time because cutoff Celsius can be adjustable, and the time to trigger a call is also adjustable by time. Now we are using +2 to +10 Celsius degree, and a call is triggered after 13 minutes. Users are at the moment very happy because of vaccines. If the vaccines exposed the temperature over or freeze, and because of this wastage, the money of the vaccine have to be paid by the local cold chain administrators. So alarming is the best and optional way.
Okay, there's probably many more discussion points, but we have to wrap up. And if you have questions, please reach out to the specific presenters. You may have, you can chase them down in the next break, corner them and ask them questions. And thanks for having been here.
And if I could just highlight again, if you'd like to hear more about the real-time temperature monitoring in Turkey, Dr. Tarkan is running an innovations cafe from 1 to 2, just outside this room. And as well from 1 to 2, you can also follow up more if you're interested in hearing more about the cold trace, which Ruth just spoke about that they used in Mozambique, also from 1 to 2, just outside the ballroom foyer. So let's shift now. I think Benjamin wants as well to just give us some teasers for what you have in the afternoon sessions.
So we have an eventful afternoon, and you need to make some choices. You cannot be everywhere. So the first session is really, you mentioned already Robert Steinglass doing a lunchtime session on the optimal number of doses per vial. And then there are some expert discussions and breakout sessions. So the first one is going to be here with Lauren Frenzel from the Gavi Secretariat doing a game show with surprises, telling us about an innovative Gavi mechanism that will help Gavi eligible countries to get more equipment. that is more efficient and better performing. So that will take place here from 2 to 3 in the ballroom. Steve McCarney from SELF will chair a discussion on solar equipment versus solar system. It's not only the discussion, I heard. They're also going to do a theatrical performance, so I don't know what's behind that, but that will take place in New York. And the discussion will be about, can we power more than just the fridge in the health facility, and how can this power be harnessed? Then Richard Anderson will have a discussion in Beverly Hills on data standards, and which are an important part to ensure that we can integrate all the different data streams into management systems. Then we're going to have the break, and then from 4 till 5, 3 more discussions. Anna Leah will talk about, here in the ballroom, about the CTC, where do we go from here, following up on the discussions we heard early on. Modibo Diko will chair a discussion on cold chain equipment management and maintenance, and how we can solve these problems that we often face about finding some equipment non-functioning and not cared after. And then also in Beverly Hills, there will be more of a discussion on how to design temperature monitoring systems. So, which is really following up on these discussions here. How can we build a system? It's not only about procuring and dropping devices into fridges, but really to the point that Oleg mentioned as well. How do we identify which users there are, who should get the alarms, how to set the alarms, and how to clarify accountability. That's it.
Great. Thank you very much, Benjamin, for the introduction, the mapping for this afternoon. So it's 11:59. Believe it or not, we got here. Give you a full hour to eat your lunch and maybe even take a nap before you get started at 1 o'clock again. To plug again for the optimal number of doses per vaccine, Robert Steinglass is on his knees pleading to invite those who have field experience to come give your viewpoints, because it'll help inform how they move that project forward. To remind everybody again, there's the manufacturer's marketplace and the project and video gallery that you can also use to fill up your time. And if you would just humor me and give a really strong round of applause to the 6 country presentations that were absolutely superb, and the 3 global updates. Thank you very much to all the 9 presenters, and I wish you all a lovely afternoon and evening. Thank you. Go eat.